So this is chapter 13. We're going to deal with all peripheral nerves. We're going to start off with a bit of a classification, and then we're going to move on with the sensory receptors, all the different types of receptors we have, and where does these information goes in the sensory, from the sensory receptors, how does it get integrated in your brain, and then briefly we'll do the different levels and perception of pain very briefly, and then we move on to the nerves, the structure of nerves, and then from there, how do they get repaired, and then we're going to talk about the peripheral nerves. Remember, peripheral nerves are of two types, one originating from the brain and the other one originating from your spinal cord. The one originating from your brain are called as cranial nerves, and the one from spinal cord are called as spinal nerves. So we're going to talk about both of them. Okay, so let's begin our chapter with a little bit of a classification. So we're finished with the central nervous system. Now we're moving on to the peripheral nervous system. From this picture that you should be aware of, the peripheral nervous system is divided into sensory, afferent division, and motor. The motor further divided into somatic and autonomic. Autonomic is the chapter 14. We'll be talking about it later. We're going to talk about all the others in this chapter. So sensory receptors. Without sensory receptors, we will not be known what is happening within our body and outside our body. So it is very, very important to have these receptors within our body and outside on our body surface. These guys are the ones that actually receive constant impulse from the environment to make sure that nothing is changing inside or outside our body, and accordingly our homeostatic balance is adjusted, right? When these receptors receive stimulus, what is a stimulus? It's the change in the environment where the receptors are located, which causes graded potential, remember graded potential, and then which leads to action potential, which is later on carried by the peripheral nerves, which is later interpreted by your brain itself. The sensory receptors are classified into different types based on their location, based on the stimulus type, right? Based on the stimulus type, depending on what kind of stimulus causes them to react, right? So if the stimulus is touch, pressure, vibration, stretch, or itch, it's called as mechanoreceptors. If those are the stimulus that make that receptor react, then it's called as mechanoreceptors. If it is temperature, then it's thermoreceptors. If it is light energy that's in your retina, it's photoreceptors. If it is chemical, any kind of chemicals, then it is chemoreceptors. Those are your taste, smell, the ones on your blood vessel walls that detect your blood chemistry. Those are all chemoreceptors. And then the last type is the most important probably that we have, is called as nociceptors. These are pain-causing stimulus. Pain is actually not a bad thing. It is an indication telling you that something is wrong, that is hurting your tissue and has to be fixed, right? So that's pain causing stimuli. These type of receptors react to those stimuli. So may it be extensive heat, cold, pressure, or any chemicals that causes pain, these receptors will react to it. These are the classification based on the stimulus type. The classification based on location, on the other hand, depends whether it is located within your body, outside your body, or found within the muscles, right? The exteroceptors, interoceptors, or proprioceptors. The exteroceptors are found on the body surface, detecting any changes happening outside in our environment. So that is your skin receptors found on your skin or in your skin. It is for touch, pressure, pain, temperature, and other sense organs like eyes, tongue, and all that. Interoceptors are found within the body walls of your blood vessels that react to changes within your body, internal environment. Those are also called as visceroceptors. They're sensitive to temperature, chemical changes, and so on. Proprioceptors are the one that keeps the motion in check. You don't stretch your ligaments or your muscles or hurt your joints, right? So those are your proprioceptors. for proper movement. Now, based on the complexity, you have either complex receptors, includes all your special organs, that's your eye, your smell, your taste, or your simple receptors that can be encapsulated, that is surrounded, that would be your dendritic endings, or unencapsulated, that's free without anything surrounding it. Okay, this includes your tactile, temperature, pain, and muscle senses. So in your book, they have mentioned each and different types of receptors that you have. You don't need to go through all those things. I do want you to remember all the classification of your receptors based on the location, stimulus type, complexity. Okay. Unencapsulated will be your thermoreceptors for heat and cold, nociceptors for pain, and your touch receptors, tactile or Merkel, hair follicles. Encapsulated includes your Meissner's, Pacinian, Ruffini, muscle spindles, Golgi tendon, and kinesthetics receptor, joint kinesthetics receptor. Again, you don't have to go into detail, just briefly list all of them. That should be enough. All right, now let's go on to what happens after the receptors receive the sensation. Once the sensation is received from either internal or external, it has to be interpreted. That is perception, conscious interpretation of these stimuli. What should be done in your body, right? So there are 3 levels that the sensory integration can take place, right? The first one is the receptor, that's your sensor receptors. That's where the stimuli is being received. Then you have the pathways, which is the circuit level, where it is transmitted to your CNS. And then the perceptual level, where it is integrated, analyzed over there. That is in your cerebral cortex. More specifically, that'll be your postcentral gyrus of your cerebral cortex. Remember from the previous chapter. So these are the 3 levels of neuronal processing happening for your sensory perception and integration. Okay, processing. At the receptor level, your graded potential is being formed. That's your receptive field. Once it is applied over there within that field, the graded potential, like for example, you see where your eyes are located. You cannot see behind your head because there is no receptive field over there. You can't receive the light energy that way, right? So that's a receptive field. So that energy is converted into graded potential, also called as receptor potential. And finally, it becomes your action potential at the first node of Ranvier and then carried to your CNS. This is a processing at the receptor level. But when it comes to special senses or sensory organs like your eyes, your nose, and all that, from the receptor potential, neurotransmitter is released and it generates your generator potential, the first order neuron. Finally, it forms your action potential when the threshold is reached. The sensory receptors, depending on which one you're talking about, does get adapted. Adapted, like if you sit on an uncomfortable chair, initially it's going to be uncomfortable. After sometimes you don't even realize that you're sitting. That is adaptation. The sensitivity of that receptor changes and it becomes less responsive, and you do not have enough receptor potential generated. Frequency is reduced. I said there are different types of receptors, right? If you have a receptor that forms adaptation fast, it's called as phasic receptor. That's for pressure, touch, and smell. But if they take a long time or they do not adapt at all, it's called as tonic receptors. That'll be your nociceptors. You don't want to be accustomed to pain. Pain is an indication telling you that something is wrong in your body, right? So you'd never want to get adapted to it. So that is your nociceptors. The slow adapting will be your proprioceptors. Like, for example, you take up yoga, for example, right? It takes a long time for your joints to move the way it does when you're doing yoga moves, right? But eventually it does adapt. That's your tonic receptors, proprioceptors, right? Okay. Circuit level processing. Over here, there's not much of processing going on, but just conduction of the impulse is happening at this level, right? Because it's a sensory information, this is going to the dorsal neuron. That means you have your ascending pathway going on. So that means it has 3 order neurons from the periphery to your dorsal horn, and from there of your spinal cord, and from there you have information going to the second through the second order neuron to your thalamus. From your thalamus, the third order neuron goes to your somatosensory cortex. So that's your circuit level. Perceptual level. Now it's a sensory information that'll be determined by the cells located in your post central gyrus. Well, what kind of information did you receive, right? Should it react to it? So the aspects of sensory perception takes place in this. Ability to detect a stimulus, magnitude, intensity of the impulse frequency itself, and spatial discrimination. Where exactly does it happen? 2-point discrimination test is done. Okay. All right. What is the result of the integration? You realize the several properties of whatever you felt. Okay. Quality, that's feature abstraction. Quality discrimination between the sweet, same, you taste something, but you can distinguish the taste between the two different things. Submodalities is what you're doing. And then pattern recognition. Have you heard this? Familiar patterns. That's what is going to happen. The sensory perception. Perception of pain, like I said, you never get used to it. It is a tonic receptor. Never get used to it. There's no adaptation in here. It is actually warning that something is wrong, that damages your tissue. That stimuli can be anything, extreme pressure, chemicals, anything, and it goes to your brain. Some pain impulses are blocked by inhibitory endogenous opioids. You do make your own opioids in your brain that actually inhibits the pain. Now let's move on to the nerve structure, right? The nerve, just like muscles, have layers surrounding it, right? We said the endomysium, perimysium, epimysium, just like that you have that, except the endings are not mysium but neurium because it's a neuron, okay? So here you have the epineuron. And then surrounding the fascicles, you have the perineuron, and surrounding each neuron, you have your endoneuron. Okay, so they're actually bundles. So the actual nerve that we know of, peripheral nerve that we know of, is bundle of axons made into fascicles and bundle of fascicles. Within that nerve, you do have their own blood vessels flowing through it as well. Okay. All right, your nerve layers, endoneurium is made of loose connective tissue, perineurium, coarse connective tissue, and then epi is your tough fibrous sheath around everything. The neurons are classified based on what they carry, what kind of information they carry, okay? If they carry just sensory information, they're pure sensory or afferent neuron. If they carry pure motor, it's pure motor or efferent nerves. Most of the nerves that has pure axons running through it are very rare. We usually have mixed, like your spinal nerves that we described, right? So mixed nerves are of different types: somatic afferent, somatic efferent, visceral afferent, visceral efferent. Okay. Again, peripheral nerves are classified as cranial and spinal nerves. Spinal nerves are all mixed nerves, whereas your cranial nerves, you do have pure nerves in them, which we are going to discuss later. Ganglia is a collection of cell bodies outside the CNS, like we mentioned in the previous chapter. We're going to talk about dorsal root ganglia over here when we get to the spinal nerves. Let's talk about regeneration of nerve fibers. When we talk about nerve fibers, we're talking about axons, right? The cell body is safe and sound somewhere else along with its dendrite. It's the axons that gets regenerated. If the cell body is destroyed, the entire neuron dies because cell body is where everything is generated. The metabolism takes place over there, mitochondria is there, so everything is happening over there at the cell body. So if that is destroyed, the entire neuron is destroyed. But if the axon is destroyed, there is a chance that actually regenerates itself as long as the cell body is intact. Okay? Now let's look at all the different stages. The first stage is the actual damage has happened, and you can see the axons are fragmented, and the myelin sheath around it forms droplets of myelin. Myelin sheath, remember, is your Schwann cells. Schwann cells is absolutely important to form a new axon. The next is the macrophages that are found. They start cleaning up that process, the area where the damage has taken place. So the fragmented axons, so the myelin sheath, all those things are taken or eaten up by your macrophages in that site. Then the Schwann cell starts to regenerate, forming a regeneration tube. Axons or Schwann cells are your neuroglial cell of your peripheral nerves, so they basically help to regenerate. Meanwhile, the axons, the cut end of the axons, forms filaments or sprouts connecting to the other end of the axon that was damaged. Okay? And the Schwann cells actually guide them to it. Now, once eventually everything is cleared up, the Schwann cells forms myelin sheath again, and the axon is completely connected together to form a single large axon filament. And that is basically how your axons or nerve fibers gets regenerated. Okay, so that concludes the general topic of your chapter 13. We're going to move on to the peripheral nerves, starting with the cranial nerves. Cranial nerves all start from your brain or parts of your brain, right? There are 12 pairs of them starting from different areas, and most of them are mixed, but some of them are pure. We're going to go through them. The cranial nerves has names as well as numbers, Roman numerals. And for exam purpose, you need to know both. You need to know the names and the appropriate Roman numerals along with it. And how do you remember all 12 of them in order? By help of this mnemonic that's there. There are a lot of mnemonics that are found online, but the one that your textbook prefers is On Occasion or Trusty Truck Acts Funny. Very good vehicle anyhow. This is in order. All the 12 neurons are being named in order. So the first O stands for olfactory, next optic, next oculomotor, then your trochlea, then your trigeminal, abducens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory nerve, and hypoglossal nerve. All 12 of them. You need to know all these cranial nerves in order, and they are Roman numerals. Okay? All right. So here is a table that describes all 12 of them. It also tells you which one is pure, afferent or efferent or mixed nerves. Okay. So for example, the first one, olfactory, or the second, optic, are pure sensory functions. They have no motor function over there. So this will be your pure sensory nerve. Okay. Oculomotor, on the other hand, is for movement of your eyeballs, and hence they're also motor. Your eye movement is maintained by 3 cranial nerves: oculomotor, trochlear, and your abducens. And you see all 3 of them are motor, pure motor functions. Trigeminal, you have a mixed nerve there. Facial, again, mixed. Vestibulocochlear, mostly sensory, but some mixed motor function. Glossopharyngeal, vagus, mixed. Accessory and hypoglossal are pure motor in function. Okay. When you go over these cranial nerves, you're going to look at this table that is being mentioned in your textbook. In this table, you have origin, course, function, and clinical testing and homeostatic imbalance. I'm not going to ask about the origin and course. You need to know the function. You need to know how to test them, and you need to know what will happen if it gets affected. Olfactory nerves, basically at the roof of your nasal cavity, you have the receptors over here, the filaments, you can see them. And it goes through the cribriform plate of your ethmoid bone into the olfactory lobe, and it goes all the way to the medial surface of the temporal lobe. The function, purely sensory, hence they help in detecting the chemical changes of your air that you breathe in. And the clinical testing, but if you give a person sniff, aromatic sniff test, right? Then you basically can detect whether the olfactory nerves is functioning well or not. So what will happen if they're not functioning? The condition is called as anosmia. Anosmia is when you have loss, partial or total loss of smell. That's your cranial nerve number 1, olfactory nerve. Number 2 is your optic nerve. Optic nerve is also sensory, pure sensory. It arises from the retina of the eye. Now, in this case, you might have to go over the course a little bit to understand how it goes. So, the vision itself, you have two things that you see. You have the medial surface of this eye, and then the lateral vision that you see, okay? This is for this eye, and this is for this eye, right? Okay. You can see how the medial tracts that receive information from the lateral side actually of the optic nerve crosses over here at the optic chiasma. Okay, it's called as decussation. And then the lateral one, fibers, just keep its course. It keeps going on the same side, but the medial fibers now the one that decussate or crosses over at the optic chiasma. Once they go further after the optic chiasma, it forms the optic tract, ends at your nuclei of your thalamus, and forms optic radiation, which ends at the tip of the occipital center. That's your visual cortex. Okay. Now, why is this important, this decussation? Because depending on where the damage is, if it happens in the optic tract, you're going to lose partial view of both eyes, right and left. But if you lose in the optic nerve, you're going to lose the vision in that particular eye. That's why you have the decussation. You need to know where exactly the damage has happened. Now, how do they test it? They test it by the Snell's chart. That's where they basically show which alphabet you can see the last line of that alphabets, right? Eye chart. You test it by moving the finger in the visual field. You just see, you can move the finger along and you can say, yes, I see it when you reach the visual field, and the same over here to check for the peripheral vision, right? You can look at the retina and see any kind of swelling going on in the retina. So all those things are the clinical testing for your optic nerve. Homeostatic imbalance, when you, again, I said optic nerve is damaged, you're completely blind in that eye. Whereas if your optic tract is damaged, your partial loss in each eye happens. Visual defects are called as anopsia. Anopsia over here. Okay, that's your cranial nerve number 2. Cranial nerve number 3 is pure motor, and it's part of one of the nerve that actually controls your eye movement. The reason why it controls eye movement is because it innervates nerves or muscles. Out of the 6 eye muscles, so your eyeball is here, and you have 6 muscles around the eyeball that causes movement to your eyeball. Out of that 6, inferior oblique, superior inferior medial rectus muscle that are innervated by your oculomotor. So inferior oblique, superior inferior medial rectus muscle. So here's your inferior oblique, superior rectus, medial rectus, inferior rectus muscle. So all those 4 are being innervated by your oculomotor. You do have partly autonomic nerve fibers running through the oculomotor nerve, which innervates your pupil constriction. Okay, ciliary muscles constricts your pupil, and lens is focused according to what you're seeing. What do you do to assess this nerve movement, right? You test for near vision convergence is tested by following the object with the eyes, and also you see for constriction of the pupils, and you can actually tell the motor nerve part of this nerve itself. So when this nerve is damaged, the muscles is going to be damaged, moving the eyes, right? So that leads to external strabismus. Strabismus is when you have crossing eye, right? So that is what is going to be caused. External strabismus, the eye rotates laterally, so outward. That's what is going to happen, okay? So when another thing you need to notice in your eye muscle, is the eye muscle keeps the eyeball in straight direction, right? So if one is weak, the pull on the other side is more, and so the eye will move that side, not towards the weak one, but towards the strong one that is still intact, causing the movement. So here's your inferior oblique, right? You have inferior rectus muscle, medial, and superior rectus, right? So if the medial rectus is not working because of the oculomotor nerve damage, then the lateral rectus is still working, right? So that'll pull the eyeball laterally, causing the eyeball to move laterally, causing external strabismus. Okay, so that is your number 3 cranial nerve, oculomotor nerve. Number 4 is also a cranial nerve that innervates an eye muscle. It's called a trochlear. Trochlear innervates only one muscle of your eye. That'll be a superior oblique muscle. Okay, so when it innervates your superior oblique muscles, so you can see over here, it innervates only one muscle. So the superior oblique muscle has a trochlea over here, hence the nerve is called a trochlear nerve. Because it innervates your superior oblique, when they don't function, the eyeball is now results in double vision, and you cannot rotate inferior-laterally. That's what causes the problem. Okay, the eyeball is now inferiorly, causing the double vision. Those two were the two nerves out of the 3 that innervates your eyeballs, right? We're going to see the abducens later on when we get to number 6. Number 5 is your trigeminal nerve. It is actually made of 3 divisions, okay? So your face can be divided into 3. The ophthalmic division, the maxillary division, and mandibular division. This is also a great chance to reinforce that the cranial nerves usually, except for one, all innervates your head-neck region, okay? Except for one, that'll be your vagus that goes or below your shoulder region or neck region, right? Rest, they're all within the head-neck region. Now let's get back to trigeminal again. 3 divisions: ophthalmic, maxillary, and mandibular. The ophthalmic division stays on the topmost portion where your eyes are, and they basically receive sensory information from the skin scalp area and as well as the cornea of your eye. So the test you're going to do to test the ophthalmic division of your trigeminal is corneal reflex test, which might be inhibited or a negative result or a false negative result when a person wears contacts often. They lose the corneal reflex in them, okay? Corneal reflex test is when you take a cotton swab and you just touch the cornea and you start blinking. That's your test for ophthalmic division of your trigeminal nerve. Maxillary division is from the eye below till the mandible portion, right? And this one receives the sensory impulse from all that area, upper teeth, cheek, upper lip, lower lid, and all that. What do? You basically take a pin and poke those areas and you feel, right? If you feel, then this division is basically working. Then mandibular division is from the maxilla below, that will be your lower part of the mandible, basically, is your mandibular division. This includes the lower teeth, chin, the temporal region of the scalp, muscles of mastication, all that stuff. So how do? You ask the person to clench the teeth and ask them to open their mouth against resistance. So they're clenching and you're trying to open, right? And move the jaw side to side. Now here are all the 3 divisions, and you can see all the nerves, how they go into all those divisions, right? Here's the infraorbital foramen. You have the nerve. So this is the nerve they actually give anesthetics to numb all the upper teeth while they're working on that. And the lower teeth basically is over here. They give injection at the mental foramen region to numb the teeth area at the lower jaw. Okay. All right. Homeostatic imbalance. Now this imbalance is called as trigeminal neuralgia. It's a very painful condition because the trigeminal nerve goes through the foramen here. You can see how you have the superior orbital fissure, foramen rotundum, foramen ovale. Because they go through these tiny areas, sometimes they get pressed because of inflammation going on at the trigeminal nerve. And when they get pressed, the entire area gets so sensitive. Even air brushing against your skin will cause pain. Okay? What do? They give analgesic to numb the pain. If not, they go and they relieve it by moving the pressing vessel or by destroying the nerve itself that causes the pain to that area. This is the 3rd nerve that actually innervates your eye muscles. It's called as abducens, number 6. And the fibers basically innervate your last muscle of your extrinsic muscle of the eye, which is your lateral rectus muscle. Lateral rectus muscle, you can see it has been reflected in this picture right over here. And this lateral rectus muscle, when loses its function because of the damage of abducens nerve, can result in internal strabismus. Remember, the external strabismus is when medial rectus gets affected, it pushes the eye towards the lateral side, right? This way. But when the lateral rectus is affected, the eye moves medially, hence internal strabismus. Okay? This is the 6th nerve. The 7th nerve is called as a facial nerve. Okay, facial nerve. We all know that it leads to Bell's palsy. It's a very common imbalance that happens when the facial nerve is affected. Most commonly, it's due to herpes simplex 1 viral infection causing inflammation in the facial nerve, which leads to damage of the structures innervating the facial nerve, damage or inhibition of the function. So the facial nerve has different fibers or branches. They have 5 branches. You can see in this picture over here, you can see all the 5 branches: temporal, zygomatic, buccal, mandibular, cervical. Okay. And this is a mixed nerve. So because it's a mixed nerve, you have both sensory and motor. So when the function is lost due to Bell's palsy, both are going to be affected, right? In your facial nerve, you also have autonomic nerve fibers running through it, which innervates your glands, which includes your lacrimal gland, which includes your salivary glands as well. So when it is affected, you're going to affect all those as well. The clinical testing that you do to assess your facial nerve is by giving taste, because it's sensory nerve fibers going through it and innervates 2/3 of your tongue anteriorly. You can give sugar, salt, sour, vinegar, bitter, quinine, and ask the patient to test it. Okay. And then, of course, symmetry of the face, because it also has motor fibers running through it. The 5 branches, temporal, zygomatic, buccal, mandibular, and cervical. If the facial nerve is affected, you have drooping on one side. How do you detect? By just looking at the angle of the mouth, your eyes, and you can ask them to whistle, because the muscle, buccal muscle, buccinator, is being affected, right? The tearing of your lacrimal gland. So if you give them any tear-causing reagents, tearing is absent. Okay. So Bell's palsy, you have drooping of your eye, drooping of your mouth, and then you have lacrimal gland secretion causing dry eyes. Salivary gland secretion is affected as well. All those will be symptom of Bell's palsy. Number 8 is your vestibular cochlear nerve, mostly sensory, but also a little bit of motor nerves going through it. The nerve fiber starts from the vestibule of your inner ear. So you can see the vestibule is located over here and the fiber starts over here. That's the vestibular nerve of vestibulocochlear. And from the cochlea here, you have the cochlear nerve, and they fuse together when they come out and then forms a vestibulocochlear nerve, responsible for hearing and equilibrium. Okay. So hearing receptors come from the cochlea, that'll be a cochlear division, and the equilibrium comes from the vestibule, that'll be a vestibular division. So how do you test it? By hearing the tuning fork. You can assess it by both air and bone conduction using a tuning fork. And homeostatic imbalance, if you can't hear, that leads to the deafness. And also, the vestibular part causes dizziness, rapid involuntary eye movements, loss of balance, vomiting, nausea, all those things will be the vestibular division part if it gets impaired. Okay. The 9th one is your glossopharyngeal nerve, which basically is for your tongue and your throat region. So you can see here you have the tongue region and the throat region. It is a mixed nerve, so you have motor and sensory. The clinical testing is to check uvula. It has to be straight. The uvula is a little thing hanging in your oral cavity. You can see that and see if there are any deviations located. You can ask the subject to swallow and see if they swallow without choking. If there is a problem with the glossopharyngeal nerve or even facial nerve, basically, or vagus, in fact, that'll cause a problem with swallowing, right? So that might lead to coughing and all that stuff. Homeostatic imbalance, impaired swallowing and tasting. The 10th nerve is the only nerve that goes past the head-neck region, which is the vagus nerve. It carries most of your parasympathetic fibers, about 80% of them. Parasympathetic fibers are carried by your vagus, hence they have to go to all the visceral organs in your body. Okay. Homeostatic imbalance, you start off with the voice box, difficult swallowing, impairment. Like I said, it also innervates your throat muscles. You can see over here. And visceral organs gets affected. It's a parasympathetic fiber. Parasympathetic division is responsible for bringing down your blood pressure, bringing down your heart rate, breathing slowly, all those things, right? You cannot survive without vagus nerve, okay? So it is not possible to have any kind of impairment that with the parasympathetic division affected, right? So it's very rare that you have. If it happens, then your sympathetic takes over completely. So the heart rate is going to be almost 150, 170. Your digestion is going to shut down. It's going to be a disaster to your visceral organs. Okay. The 11th nerve is your accessory nerve. This is the nerve that people do not understand. They don't know whether it is your cranial nerve or your spinal nerve, because technically they start off, if you look at this, start off at the C1, C5 of your spinal cord over here, right over here. You can see how they start off. They re-enter the foramen magnum and they come out. Okay, so but they're starting off at the spinal cord. So your accessory nerve, number 11, it follows the pathway to your vagus nerve, right? It's a mixed nerve, although it does have innervation to trapezius and sternocleidomastoid. So how do you test that? By asking them to shrug their shoulders, right? And asking them to rotate the head. They turn their head this way. You place a hand on their cheek and ask them to force to move your arm. So they turn. Now they can check the sternocleidomastoid against resistance if they turn. Homeostatic imbalance will lead to problem with shrugging the shoulder, and you can turn towards the injury site of the sternocleidomastoid. That is your accessory nerve. The last one, number 12, is your hypoglossal nerve. Hypoglossal, the name tells it, is your tongue innervation. So what is it? Primarily motor function, even though it is mixed. If you ask a person to protrude and retract your tongue, you can tell. The deviation is towards. So if you basically have a problem with this, a person cannot protrude their tongue. And the deviation of the tongue is towards the affected side, and that side eventually gets atrophied if it is not fixed, right? This will be the last nerve of your cranial nerve section. This is the 12th hypoglossal nerve that you have. Again, the course and origin is not so important, maybe except for the optic nerve, but the rest is not so important. I would like you to focus on function, clinical testing, and homeostatic imbalance. Now we're moving on to spinal nerves. Spinal nerves, like we mentioned before, are 31 pairs of mixed nerves. All spinal nerves are mixed nerves. There is no pure sensory or pure motor spinal nerves in your body. Depending on where they are originating from, you have different types of spinal nerves. You have 8 cervical nerves starting from C1 to C8, 12 thoracic, T1 to T12, 5 lumbar, L1 to L5, 5 sacral, S1 to S5, and 1 coccygeal nerve that you have in your body. Before you understand, you might need to go back to the spinal cord anatomy and review it. Okay, so here you have the 8 spinal nerves that will be your cranial nerves, C1 to C8, thoracic, T1 to T12, lumbar, sacral, and coccygeal. Don't forget the enlargement that you have in the cervical region and lumbar enlargement that you have in your spinal cord. Okay. Let's go to this picture. And this is basically the same picture that you had seen in the previous chapter. Okay. Remember, once again, you have the H-shaped gray matter. You have your dorsal end, and you have the ventral end of your, okay, this will be the dorsal, okay, dorsal root over here. This will be the dorsal root, and this will be the ventral. Here's the ventral root over here. Okay, because the ganglia is in this side. It's only one dorsal root ganglia. Dorsal is for sensory, ventral is for motor. Okay. Now these two join to form your short spinal nerve. Okay. Now the spinal nerve, as soon as it comes out of your vertebral column, it actually divides. Okay. It divides into ramus. You have your dorsal ramus, you have your ventral ramus, and you have your rami communicans. We're going to talk about all those things now. Okay. All right. So let's talk about the roots. The ventral root is the motor and goes to the skeletal. Dorsal root is sensory. It goes up from the peripheral to your CNS in the body. As soon as the spinal nerve is formed, it comes out and it branches. You have the dorsal ramus, ventral ramus, and the meningeal branch and rami communicantis that we're going to talk about in the next chapter. That's the autonomic. Now let's talk about the ramus. The dorsal ramus, let's look at this picture for now, and you can actually tell the course of all the ramus. Okay. Here's your dorsal ramus right over here. You can see how they go and they innervate all the back muscles. Okay. The rami communicans, we'll talk about that later. And now let's talk about the ventral ramus. The ventral ramus, except for your thoracic region, they basically form a complex network of neurons called as plexus. Okay, except for thoracic, T2 to T12, except for this region, everywhere else it formed plexus. What kind of plexus? Cervical plexus, brachial plexus, lumbar plexus, and sacral plexus. Okay. These plexus in turn give rise to your peripheral nerves, the nerves that we know as ulnar nerve, your radial nerve. All those nerves come from these plexus. Again, the dorsal rami goes to your back, innervating the skeletal muscles. Ventral rami forms plexus except T2, T12. What happens in T2, T12? The ventral rami forms intercostal nerves and innervates your ribs, the muscles of your ribs, the thorax, and abdominal wall. Okay, so that's basically what happens to all these rami that you have. We're going to talk about all the plexus, starting with cervical plexus, and then we're going to discuss which important nerve, peripheral nerve, that starts from that plexus. Cervical plexus starts from C1 to C4 spinal nerve, or ventral rami, to be more specific. And from that cervical plexus, you have one major nerve forming that is called as phrenic nerve. Phrenic nerve innervates your diaphragm. So without the phrenic nerve, your diaphragm will not function and you cannot breathe and you might even die. Okay, so that's all you need to know. C1 to C5 or C4 forms your cervical plexus. And from that cervical plexus, the main important peripheral nerve is your phrenic nerve that innervates your diaphragm. Okay, you do not have to worry about all the other branches from your cervical plexus. Moving on to the brachial plexus. This is the most complex plexus that you're going to see. Okay, the brachial plexus starts from the cervical and your T2 of your plexus. C5, C8, and T1, sometimes T2, forms the ventral rami, forms your brachial plexus. Okay. These brachial plexus divides and reunite and divide and reunite. And so there's a complex major branches that these plexus give rise to. Okay. First you have roots, 5 of them. Then you have trunks, upper, middle, lower. Then you have divisions, anterior and posterior. Then you have cords, lateral, medial, posterior. From that you have your peripheral nerves. Okay. So here's an easy way for you to remember all of them. So first you have the roots. That'll be all the ventral rami, C5 to T1. And then from that roots, the C5 and C6 join together to form upper trunk. C7 forms middle trunk. C8 and T1 forms lower trunk. Upper, middle, lower divides into anterior, posterior divisions. Okay. All the posterior divisions join together to form posterior cord. The division anterior, both upper and middle, forms your lateral cord, and the lower anterior forms your medial cord. Okay? The lateral and medial together gives rise to musculocutaneous, median, and ulnar. The posterior gives rise to radial and axillary. Okay, radial and axillary. So this is basically what you need to remember. The roots from which the trunk starts, and then divisions, and then the cords, and the major terminal or peripheral nerves that forms from it. You need to know all of them. Okay, this basically tells where and which muscle they innervate. Okay, you don't have to worry about this portion. I want you to remember this flow chart better for your brachial plexus. Okay. All right. Next plexus that we have, is your lumbar. Lumbar is L1 to L4, innervates your thigh, abdominal wall, and psoas muscle. Out of this lumbar plexus, you have two major nerves. That'll be your femoral, anterior thigh, and the medial thigh, and the obturator that goes medial, where your adductors are located. Okay, so you can see how the obturator goes through the obturator foramen of your hip bone right over here, innervates your medial, and the femoral goes all the way up anteriorly and medial portion of your leg as well. And that's all you need to know in your lumbar. Sacral, L4 to S4, innervates your back, that is the posterior buttock, lower limb, pelvic structures, perineum. The main nerve is your sciatic nerve. Sciatic nerve is the longest, thickest nerve of your body. Okay, it innervates all the posterior muscles as it goes along the leg and then goes all the way to your big toe, right? Sciatic nerve is actually composed of two nerves. You can see over here the tibial nerve, and then you can, right over here, the common fibular and the tibial. Together, they form your sciatic nerve. When you have a sciatica, this is the nerve that gets pinched with the bulging herniated disc, right? So you can see the pain from the sciatica is going to go posteriorly all the way from the buttocks region, goes all the way to the back, goes all the way to the foot. That's sciatica right there. Okay, the nerve basically is pinched and the pain is distributed on the posterior surface of the leg. All right, those are all the spinal nerves, but you do have innervation of skin. All spinal nerves except C1 participate in something called as dermatomes. Dermatomes are area of skin innervated by the cutaneous branches of spinal nerve. They overlap, so it's not perfectly organized like this, but they do overlap. This basically tells you which ventral rami innervates which part of your skin. And your joints, whichever innervates in that area, skin muscle, whatever joint is located there will also be innervated. Okay? Now, this portion is a review of what we have done in previous two chapters, how your muscles get innervated. You know this whole process. Neuromuscular junction, that's where your axon terminal is going to be located. That's where your neurotransmitter are going to be released into the synaptic cleft, forms a graded potential, eventually becomes your action potential and gets generated and causes contraction of your muscle. Okay, I am not going to go through all of these. This is for smooth muscle, so we're not going to go through all of this. Now, control. We discussed about the sensory receptors or control levels before. This will be the motor control and their levels. Start off with the segmental, then the projection, and the pre-command level. Now, this is motor. So where is it going to start? The information is coming from the CNS, not from the sensory receptors, right? This is motor. Okay, so let's look at it. The highest, which is the pre-command level, is your cerebellum and your basal nuclei. Remember, I have told you that the blueprint is being made at your cerebellum. And then the middle is your projection level. That's where your pre-central gyrus is located, and that's where information is being processed and it's conveyed down to the segmental, which is the lowest level. That'll be your spinal cord. From the spinal cord, the information goes out. Sensory input, we already know what it is, and this is your motor output. Okay. Don't forget, this is a descending tract, so you're going to have two neurons, the upper motor neurons and the lower motor neurons at the lowest level. Okay. Now, reflexes. Now, the reflexes basically forms an arc. With all the components that are involved, it forms an arc. You start off with the receptor, and then it is transmitted to your CNS through your sensory neuron, goes to the integration center, that is your CNS. From there, the information process response is sent to the motor neuron, to your effector organ, which is your muscle or your gland. So you need to know all the components of your reflex arc. Now, this is in general reflex arc. Any reflex arc, like for example, a pinprick, like you see in this picture. Okay, the pain receptor is the pain stimulus is taken by the receptor to the sensory neuron, dorsal over here. You can see the ganglia here, to the dorsal horn, and through the inner neuron, the information is integrated in the gray matter, and then through the motor neuron, information goes to the muscle, and you move your hand from the pin that is poking you, right? So this is basically a general reflex that you have in your body that you're born with. Okay, you're born with all these things. Okay, let's look into other complex reflexes that you have in your body. Okay, spinal reflexes are the first thing that your doctors do when you go to with any kind of neural problems, right? Why? Because that's a pathway. If that pathway is good, they can check the other things, right? Your somatic reflex is very important to assess the condition of your CNS in general. Out of all the somatic reflexes, some are the things that we actually test, right? It's the stretch and Golgi tendon reflex that we have in our body. This makes sure that your muscles moves properly. Now, your muscles, not all of them are contractile in nature. Some of them are non-contractile muscle fibers that are purely there to detect how much the muscle stretch is and all that stuff, right? The muscle spindles are these specialized muscles that are located within that muscle that actually measures the length of the muscle and informs your CNS, so you don't overstretch your muscle. Golgi tendon organs are the ones that are detecting the tension of the muscle and the tendons that are located. So in your book, they go into detail about the muscle spindles. I'm not going to go into detail. Again, muscle spindles are non-contractile structures that are there for the length, detecting the length of your muscle. So I'm going to go over all the main reflexes that you have. We're going to start off with the stretch reflex, right? So here's a classic thing, the stretch reflex. When you go to the doctor's office, they do a stretch reflex. That is your patellar reflex, knee jerk reflex, okay? So what they're doing when they're tapping your patella is actually they're exciting a patellar ligament that is located over there, right on top of your patella, right? So when they excite that, that's basically a stretch reflex, right? That's your muscle spindle that is located, that they're activating. So tapping that ligament excites your muscle spindles of your quadriceps. Remember, quadriceps are in the anterior part, right? It helps your leg to extend. So when they excite that information, okay, the muscle spindle goes over here through your, because it is sensory, it goes to the dorsal horn, integrates, and from the spinal cord, the motor, two neurons start. One neuron goes to your quadriceps and the other one goes to the hamstring, okay? The one that goes to the quadriceps, what it does, it causes it to contract. Okay, when it contracts, the knee is extended. At the same time, you don't want the hamstring, which are the flexors, to contract, right? So the second neuron, 3B over here, make sure that the antagonist does not resist the contraction of the quadriceps. That's basically what causes you to kick. Okay, this is a classic excitation of your muscle spindle. That's your stretch reflex that is being tested at the doctor's setting. The next reflex that you have is something called as Golgi tendon reflex. Again, it helps to prevent damage due to excessive strength and helps to produces muscle relaxation in response to the tension itself. Here again, you can see over here, Golgi tendon of your quadriceps over here is located. Okay, the information goes, once it is excited, the information goes through the sensory neuron to your dorsal horn again. And then two neurons starts from the motor or ventral horn. One goes to the quadriceps, one goes to the hamstring. Would this cause it caused, look at this. This one, the afferent antagonist muscle causes to contract, while the one that is being stretched is being relaxed, because you don't want it to overstretch, because Golgi tendon is for stretch, right? So you relax this muscle while the hamstring is contracted, right? So that basically is an example of your Golgi tendon reflexes. You have many other reflex. The other one is the flexor extensor cross extensor reflex. Like when you forcefully try to pull the arm against resistance, what happens is the information goes basically from that stimulus site, again goes through that two neurons. One goes to the biceps and one goes to the triceps of the same arm. And you're trying to flex the bicep. At the same time, the antagonist is being relaxed. Now, cross extensor means there's another inner neuron apart from these two, goes to the other side of the body and causes the opposite effect of that limb. So in this case, the flexor is inhibited and the extensor is stimulated, causing you to extend the other arm. So if one person is pulling one arm forcefully, you automatically extend the other arm. Hence, flexor cross extensor reflex. Contralateral side is extended while the stimulated side is withdrawn. The other type of reflexes are superficial that can be caused cutaneously, like stroking the sole of your feet. Lateral aspect of it causes downward flexion of your toes, and this basically tests your corticospinal tracts. It's called as plantar reflex. If this downward flexion is not noticed, then you end up with something called as Babinski sign, which is normal in younger people, infants. But in adults, it shows that there's a problem with the corticospinal tract itself. Other reflexes, abdominal reflex, not well recorded because of a lot of stimulation is not enough for that. We basically conclude the reflex. This concludes your chapter 13 of your book.